It is my pleasure to introduce today's speaker, Laura Marchiano. Laura has been a respiratory therapist at the Hospital of the University of Pennsylvania for the last 12 years. Now, for the past 2 years, she is focused on the home ventilation clinic at Penn Medicine's Fishman program for home-assisted ventilation. Their multidisciplinary team specializes in the needs of patients of chronic respiratory failure so that they can live safe and productive lives at home. So please help me welcome Laura.
Okay, my name is Laura Marchiano, and again, I'm the home ventilation specialist here at the Hospital of the University of Penn. So today we're going to discuss transitioning our non-invasive ventilation patients from acute care. I am receiving an honorarium from Draeger, so I would like to thank them for that. So our objectives today are to have a better understanding of non-invasive modes of ventilation, how to improve patient comfort to increase patient compliance, and to understand the importance of patient-family education within the hospital setting prior to transitioning to home or a long-term care facility. The patients we're going to focus on today are chronic hypercapnic respiratory failure. The airway disease we'll focus on will be COPD, and we'll focus on neuromuscular diseases such as muscular dystrophy, spinal muscular atrophy, ALS, and spinal cord injuries. Some early symptoms of respiratory failure include morning headaches, daytime sleepiness, confusion, and orthopnea. Criteria for obtaining a non-invasive ventilator or qualifying for one. For a COPDer, you have to have the COPD diagnosis and you need an ABG CO2 greater than 52 millimeters of mercury. For our neuromuscular patients, you have to have a CO2 while awake greater than 45. A better way or an easier way to qualify our neuromuscular patients would be with a NIF or a MIP less than 60 or an FVC less than 50% predicted. Now, the numbers that I got here were from a local DME company. It's important to know that the criteria varies with different insurance companies. For Medicare patients on a national level, they're discussing the criteria that will qualify those patients. So you now know that your patient needs some kind of assist at night because of their hypercapnia. So let's discuss the difference between a respiratory assisted device, or RAD, versus a ventilator. So a RAD, the pros, they're lightweight, they have a built-in humidifier, and they have automated comfort settings. The cons, no external battery, they have limited modes of ventilation, and there are no alarms. For ventilators, they have built-in batteries, they have alarms, the modes overlap hospital ventilator settings, so they have more sophisticated modes, and they also have more comfort adjustments to make the patient more comfortable. The cons, they're heavy. They're 7 to 18 pounds, and they don't have a built-in humidifier. So you decided that your patient needs a ventilator. Now let's discuss interfaces. You are only as good as your mask. This is important. So some of the masks out there, we have full face masks. The advantages of a full face mask would be that the patient can breathe out of their mouth or their nose. The barriers come in a gel, foam, or silicone. Disadvantages, some patients are claustrophobic. Also, patients who wear glasses have a hard time fitting that over the device and over the bridge of the nose. There are hybrid masks. Some advantages would be that patients are able to wear their glasses, which make them feel more comfortable. They can breathe through either their mouth or their nose, and patients tend to be less claustrophobic. So you'll notice in these pictures that there are nasal cushions, and they also have hybrid masks that have nasal prongs. Nasal masks. There are nasal pillows, nasal cushions, and nasal masks that go over the bridge. The advantages to this, that patients are able to speak and communicate. It tends to be less claustrophobic for some of our patients. Disadvantages include you have to sleep with your mouth closed. Also, increased unintentional leak with higher pressures. If you have too high of a pressure, you're going to leak everywhere. So what's the difference between an unintentional leak and an intentional leak? Well, the patient needs to exhale their CO2 somewhere, whether that's through the mask or whether that's through the circuit or a whisper swivel. It's important to know that that intentional mask is there for a reason and that that's where your CO2 is being exhaled. But the unintentional leak would be an ill-fitted mask or the mask moved over too much. So how do you fix an unintentional mask leak? I think the best way to do this is to spend time with your patient. Make sure that you're adjusting those straps just so that it's tolerable, but not so tight that it's going to create skin breakdown. If you are still finding an unintentional mask leak, make sure you're using the right size, but also they have chin straps available. What's great about the chin strap is that the patient is still able to open their mouth to talk, but it keeps the mouth closed while they're sleeping. Another thing that I learned from one of my patients who had a silicone barrier to their mask was that they were really sweaty and oily at night, and they had a huge unintentional leak that was incredibly frustrating for them. And they started using skin prep. So they skin prepped their face and then put their mask on, and it fixed their leak. Also, for our neuromuscular patients especially, they get turned every so many hours at night. And what happens is when the caregiver or nurse is turning the patient, they have an unintentional leak after that. So we try to remind them that, after they're turned, they need to readjust the mask and make sure that they have an acceptable leak. So you've got your ventilator. You have an interface that is comfortable for your patient. Now let's discuss modes of ventilation. We have spontaneous timed or ST, timed, pressure control or PC, and volume assured pressure support or VAPS. Spontaneous mode. We don't set a backup rate, and every breath is flow cycled. This is not a preferred mode of ventilation for our patients. So if you look at the pressure time curve, you'll see that there aren't many consistencies. The patient can initiate the breath whenever they want. The tidal volumes are going to vary breath to breath, and the breath is going to end whenever the patient wants it to. That being said, again, we don't use this in this specific patient population. Spontaneous timed or ST. This is your classic BiPAP mode. Clinicians are going to set a backup rate, an inspiratory time, and a cycle percentage. So the cycles are going to differ with your spontaneous versus your timed breaths. The spontaneous breaths are the patient-initiated breaths, and the breath ends with a cycle that is flow cycled based on your peak flow percentage, and we'll get into cycle later. Your timed breaths are based off of your backup rate, and the breath ends at the end of that inspiratory time. So if you look at the pressure time curve, you'll notice that the spontaneous breath, the tidal volume is a little bit smaller than the backup rate breath because the I time is consistent. We use this mode a lot with our COPDers. We tend to avoid this in our neuromuscular disease unless they have they're at a mild point in their progression. Timed mode. In this mode, the IPAP and EPAP cycling is purely machine triggered based off of set backup rate. I've never used this mode. I don't know of anyone who has. I don't know what patient population this benefits, but if anyone out there has more knowledge than me, I would love to hear from you. Now we have pressure control. The clinician sets the backup rate and the inspiratory time. It's a fixed inspiratory time for every breath, whether the patient is initiating the breath or whether it's a backup rate breath. So you'll see the consistencies between the breath on the pressure time curve. So the patient spontaneously triggered the breath, but they're ending the breath at the same time because that I time is constant. We use this a lot with our neuromuscular patients, and we tend to avoid it with our COPDers, mainly because they find it uncomfortable. I think it's really important to understand the difference between ST and PC when choosing a mode for your patients. So in the table here, you'll see that you can set a backup rate for both modes. The inspiratory time will vary for your ST mode. Remember, you're only going to get a set I time on the backup rate on those timed breaths. But in pressure control, the I time is constant with each breath. Your tidal volume is also going to vary because of the spontaneous breaths, whereas with pressure control, because of that constant I time, your tidal volumes are going to be pretty consistent. Cycling for the spontaneous breaths in ST, it's going to end based on your flow percentage or based on your I time. But for pressure control, you only set an I time. ST is useful for our COPD patients and for our mild neuromuscular patients. We use pressure control for our moderate to severe neuromuscular patients. Drawbacks of ST, again, you're going to have variable tidal volumes, but for pressure control, you could have patient asynchronate and they could breath stack. So it's just something to be mindful of. So why not VAPS or volume assured pressure support? With this mode, inspiratory pressures will vary to reach a preset target tidal volume, which is AVAPS, or targeted alveolar ventilation, which is IVAPS. So if you look at the picture, you notice that we have a target tidal volume and we set an IPAP min and an IPAP max. So the pressure will always stay between those two. What's great is that the pressure will increase or decrease as needed to reach that target tidal volume. So you know your patient is always ventilating. It's great for patients when they turn over, if there is a leak, that pressure is going to increase to make sure that they're getting that volume so that we know that they're ventilating at night. VAPS can be delivered in ST or in PC, and our average tidal volume that we start with is 6 to 8 cc's per kg of ideal body weight. They also have a VAPS with an auto EPAP mode, or AE. I like to think of this as an accessory to ST mode. The only difference between this and ST is that you set two EPAPs, an EPAP min and an EPAP max, and this is going to help overcome any kind of obstruction that your patient has. So we use this mode a lot with our COPDers or with our obesity hypoventilation syndrome patients. We tend to avoid this mode for our neuromuscular patients unless they have a known obstruction or mild neuromuscular disease. So you picked out your ventilator, you have your interface, you know what mode you're going to choose. Now, how can we make micro adjustments to make that patient as comfortable as possible? So let's break down the delivery of a breath. Initial vent settings, we start with a targeted tidal volume of 6 to 8 cc's per kg of ideal body weight or patient comfort. We use an EPAP of 4 to 8, higher for our obese patients, or you could use the previous EPAP level or CPAP level that they had, up to a max of 12. We start with an IPAP min of 5, higher above your EPAP level, and an IPAP max of 20 to 30. So you can go above 30, and a lot of our patients do need it, but you would go higher if you're not reaching your targeted tidal volume and your leak is still within normal limits. So let's look at our pressure time curve. So the breath starts off at the EPAP level, it's triggered, then you rise up to your IPAP level, and then the breath ends either based on your I time or your cycle percentage back to your EPAP. So we're going to break each of these down, and I'm going to give you some pointers as to how to make your patient comfortable by asking the right questions. Trigger. When you want a breath, is the ventilator giving you that breath? Is it too hard to initiate the breath? Is it giving you a breath when you don't want one? If you're in a flow trigger, the lower the number, the more sensitive it will be. So if a patient says it's giving me a breath when I don't want one, I'm going to increase that number to make it a little less sensitive, and vice versa. Your rise or slope is measured in seconds or milliseconds, depending on your machine. Rise is how quickly the breath is delivered from initiation up to your IPAP. It tends to be 1 to 6 seconds or 100 to 900 milliseconds. So questions I'll ask: is the breath going in too fast? Is it taking too long for the breath to go in? The lower the number, the faster the breath reaches IPAP, and the higher the number, the slower the breath reaches IPAP. I tend to start right in the middle, and I'll start asking these questions. If the patient isn't understanding the question or they just aren't sure, I'll go from one extreme to the next. So I'll start at 1 so they see how fast it feels, and then I'll go straight to 6 so they see how slow the breath goes in. And then we'll kind of work our way in the middle to figure out what makes them most comfortable. So remember, COPDers are air hungry. They tend to like a faster a faster rise or slope. And our neuromuscular patients, they have weak diaphragms, so they like that slower rise time. Your inspiratory time. It's your duration of the inspiratory phase. Is the breath too long? Is the breath not long enough? A quick I time would be less than 1 second, which is our COPDers tend to like that. That also gives our COPDers a longer expiratory phase. Slow I time would be greater than 1 second, and our neuromuscular patients tend to like that. Again, I start at 1 second. I'll start asking these questions, and if they aren't sure, if they say they think it feels okay, I'll go from 0.5 second I time straight to 1.6. Just so that they see the difference, they feel the difference, and then we find common ground and make them comfortable. Cycle. When inspiration stops and exhalation begins, the proportion of peak flow has to drop before the breath kicks off. So what I'll ask the patient, when you want the breath to end, is it stopping when you want it to? Is the breath ending too quickly, or is it lasting too long? The higher the percentage, the shorter the breath. Our COPDers tend to like a higher number. Lower percentage means the breath is going to hang on a little bit longer. That's for our neuromuscular patients. I'll start at 50%, and again, ask those questions. If they aren't really sure what I'm asking them, it can be confusing. I'll go straight from 75 down to 25 and then figure out what they like best. So now you have your mode, you've made all of your micro adjustments. Now we have to see if this is the right mode for them, if their CO2 is dropping overnight. So here at Penn, we have transcutaneous CO2 monitoring. This is a less invasive way to monitor someone's carbon dioxide level, and it allows us to make multiple ventilator adjustments without sticking them for ABGs throughout the night. ABGs are painful, they're invasive, and when you're doing a titration, it could take a while for you to get the CO2 down to to your goal CO2. So you don't want to stick the patient 5-6 times overnight. So transcutaneous monitoring is just an added bonus for us. So now you're ready to transition your patient to home or a long-term care facility. So let's talk about patient family education, our DME companies, and home monitoring. In a study done in Canada about transitioning patients from acute care, they stated that RTs and RNs are the main source of education. It's important to talk to your patient about the rationale for ventilation. Why do they need that ventilator? Talk about their respiratory physiology, their disease progression, and how increased carbon dioxide really affects the body. It's important that they understand the intentional leak. You don't want a patient to go home and say, my mask is leaking, and start taping their mask where they're supposed to be exhaling their carbon dioxide. Also, self-efficacy. Make sure that the patients understand their alarms enough that they can make an adjustment if needed, mainly your circuit disconnect or low minute ventilation. Know that you need to adjust your mask or interface. Also cleaning, make sure they know what to clean their ventilators and their equipment with. One of the great quotes from that study, some of the things that went really well were the staff at the rehabilitation center. The RT there spent a whole day of training, not only me and my immediate family, but extended family and one of my best friends. Airway clearance. I want to make sure that my patients know how to get rid of secretions and what to do. So whether that be a cough assist device, nebulizers, PEP or flutter devices, I want to make sure that they feel comfortable knowing how to use them. A cough assist is typically recommended for patients with an FVC less than 50%, or a peak cough flow less than 160 liters per minute, or if they have a history of pneumonia or mucus plugging. Our settings, we tend to start off between 30 and 40, sometimes lower depending on what they can tolerate. We tell our patients to do 5 sets of 5 coughs, once to twice daily when they're well, and increase the frequency when they have a chest cold. One of the reasons that we like our patients to use the cough assist once or twice daily is not only for lung expansion, but also we don't want them taking it out of their closet once every 6 months when they feel congested and they don't know how to use it and it could create pneumonia. So we want them to feel really comfortable with the cough assist. Your DME or durable medical equipment company. It is so important to have a good relationship with your DME company. The DME brings supplies to the patient. They offer documentation and insurance screening. They go to the home and caregiver screening, education for patient and caregivers, and we work with DME companies that offer home monitoring. Why is remote data monitoring so important? This gives us as clinicians the ability to look and see how often our patients are using the machine, if they're having any issues with leak, and basically how compliant they are from afar. Here's an example of what we look at. You can see right here that the patient goes on their ventilator at 8:30 at night and comes off at 6 a.m. But around 11 o'clock, you'll see that the tidal volume completely drops off. And that coincides with an increased leak. So we know that we can ask the patients, and again, a lot of times this happens with our neuromuscular patients at the same time of night. We can find out what's going on. Is that when you take a break? Is that when your nurse is turning you? Then we can make sure that we're having good communication with the nurses about readjusting their mask post-turning. DME involvement prior to discharge. We like when our DME company sets the home ventilator up for several days in the hospital prior to discharge. This transition to the new machine happens in a monitored setting. The patient knows exactly what machine they're going home with or to the long-term care facility with. We also ask them to set up remote ventilator data monitoring so we can start monitoring the patient immediately. At this time, they also offer training for the patients and for the caregivers, and they'll schedule a post-discharge home visit. So they'll do the home discharge, discharge home visit. There should always be great communication between the patient caregiver and the outpatient clinician, and the DME is in the center of that. We always make sure that the DME company, everyone has the contact number, the patient, the caregiver, and they offer ongoing closed loop communication. They're going out to see these patients at home. So if there are any issues, they can contact us. It's a beneficial relationship for both the clinician and the patient. Just an example of a DME schedule at home. Week 1, potentially daily, depending on how comfortable the patient is. Week 2, 2 to 3 times, and it tapers off. By the time you get to week 4, hopefully the patient is all set up, doesn't have any questions, and you can, they'll just go monthly or as needed for medical supplies. It is important that a good DME company will not disappear post-discharge. In summary, I hope that you understand your ventilator modes and to make micro adjustments with your trigger, with your rise or slope, with your eye time and your cycle. Make sure your patient has a comfortable and functional interface. Watch for unintentional leaks. And start your patient education early and prior to discharge. The patients often, they feel supported. The family feels supported when you involve them and when you start talking about their disease process. Make sure they understand their ventilator and how important airway clearance is, and involve a trustworthy DME company for home monitoring, and make sure that that DME company provides closed loop and frequent communication. I'd like to acknowledge the Fishman Program for Home Assisted Ventilation and our Penn RT department. And please reach out if you have any questions or any conversations you want to have. Please reach out. I'd love to hear from you.